Dr. Baliga here. The fact that you're listening to this podcast means that you have a high CQ. What is CQ? CQ is curiosity coefficient. That is, you have a growth mindset for learning, which puts you in the top 1% of all individuals who's trying to better know a discipline, the discipline of medicine that is characterized by complexity and ambiguity. The coronavirus pandemic is also complex and ambiguous, and we need to continue to strive to know more about this pandemic because sooner or later we'll all be seeing patients who will be affected by this condition. This podcast is on the FDA's Emergency Use Authorization or EUA for Remdesivir. Why did the FDA give this authorization for this medication? One reason is a lot is known about the safety of this medication, and the hope is it can be repurposed for the job at hand. The goal is not only to save lives, but to allow countries to relax the lockdowns which are strangling their economies everywhere. As you all know, it's too short a time to find therapies which are life-saving because testing requires months to years. But the hope with Remdesivir is from the NIH trial which I discussed in an earlier podcast. Preliminary results from this study suggest that patients who received Remdesivir had a 31% faster time to recovery than those who received placebo with a p-value of 0.001, that is less than 0.001. Specifically, the median time to recovery was 11 days for patients treated with Remdesivir compared with 15 days for those who received placebo. This means patients will have shorter duration of time in hospitals and would save PPE, which is in short supply. What is the mechanism of action of Remdesivir? Remdesivir is a nucleotide analog. It is an adenosine nucleotide prodrug that distributes into cells where it is metabolized to form the pharmacologically active nucleoside triphosphate metabolite. Metabolism of Remdesivir to Remdesivir triphosphate has been demonstrated in multiple cell types, and this Remdesivir triphosphate acts as an analog of ATP and competes with natural ATP substrate for incorporation into nascent RNA chains by the SARS-CoV-2 RNA-dependent RNA polymerase. And this in turn results in delayed chain termination during replication of the viral RNA. Whereas Remdesivir triphosphate is a weak inhibitor of mammalian DNA and RNA polymerases with a low potential for mitochondrial toxicity. In other words, its structure mimics one of the chemical letters that makes up the alphabet of the virus's genetic code, which is written in a molecule called RNA that is similar to but not identical with DNA. The ill-fitting chemical letter comes up the virus's replication mechanism. Remdesivir's effect is not dramatic. It improved patients' recovery time from 15 to 11 days. And there was no statistically significant difference in mortality between treated and untreated patients. However, as I discussed earlier, a 4-day reduction in stay length will reduce the disease burden on hospitals. The FDA issued an EUA, that's the Emergency Use Authorization, to permit the emergency use of this unapproved product, Remdesivir, for treatment of suspected or laboratory-confirmed Covid-19 in adults and children hospitalized with severe disease. How does the FDA define severe disease? Severe disease is defined as patients with an oxygen saturation of less than 94% on room air, or requiring supplemental oxygen, or requiring mechanical ventilation, or requiring ECMO or extracorporeal membrane oxygenation. The black box warning on Remdesivir is this EUA is for the use of Remdesivir to treat Covid-19. Remdesivir must be administered by IV infusion. Healthcare providers must submit a report of all medication errors and all serious adverse events related to Remdesivir. The optimal duration for Covid-19 is unknown. Under this emergency use authorization for Remdesivir to treat Covid-19, the suggested dose for adults and pediatric patients weighing equal to or greater than 40 kilos, requiring invasive mechanical ventilation and or ECMO, is a single loading dose of 200 milligrams infused IV over 30 to 120 minutes on day 1, followed by once daily maintenance dose of 100 milligrams infused IV over 30 to 120 minutes for 9 days, that is days 2 through 10. The suggested dose for adults and pediatric patients weighing greater than or equal to 40 kilos, not requiring invasive mechanical ventilation and or ECMO, is a single dose of 200 mg infused IV over 30 to 120 minutes on day 1, followed by once daily maintenance doses of 100 mg infused IV over 30 to 120 minutes for 4 days, that is days 2 through 5. If a patient does not demonstrate clinical improvement, therapy may be extended for up to 5 additional days, that is up to a total of 10 days. This authorization says in pregnancy, Remdesivir should be used during pregnancy only if the potential benefit justifies the potential risk for the mother and the fetus. In patients with renal impairment, the pharmacokinetics of Remdesivir has not been evaluated in patients with renal impairment. Use in patients with renal impairment are based on potential risks and benefits. Patients with eGFR greater than or equal to 30 mL per minute have received Remdesivir for treatment of Covid-19 with no dose adjustment of Remdesivir. All patients must have an eGFR determined before dosing. It is not recommended in adult and pediatric patients older than 28 days of age with an eGFR less than 30 mL per minute, or in full-term neonates with serum creatinine greater than or equal to 1 mg per deciliter, unless the potential benefit outweighs the potential risk. In patients with hepatic impairment, the pharmacokinetics of Remdesivir has not been evaluated in patients with hepatic impairment. It's not known if dosage adjustment is needed in patients with hepatic impairment, and Remdesivir should only be used in patients with hepatic impairment if potential benefit outweighs the risks. Hepatic laboratory testing should be performed in all patients prior to starting Remdesivir and daily while receiving Remdesivir. Warnings: there are limited clinical data available for Remdesivir. Serious and unexpected adverse events may occur that have not been previously reported with Remdesivir use. Infusion-related reactions have been observed during and or have been temporarily associated with administration of Remdesivir. Signs and symptoms may include hypotension, nausea, vomiting, diaphoresis, and shivering. If signs and symptoms of a clinically significant infusion reaction occur, immediately discontinue administration of Remdesivir and initiate appropriate therapy. The use of Remdesivir is contraindicated in patients who are with known hypersensitivity to Remdesivir. Increased risk of transaminase elevations. transaminase elevations have been observed in the Remdesivir clinical development program, including in healthy volunteers and patients with COVID-19. In patients who received up to 150 mg daily for 14 days, ALT or alanine aminotransferase elevations were observed in majority of the patients, including elevations up to 10 times baseline value in one subject, without evidence of clinical hepatitis. No grade 3 adverse events were observed. Transaminase elevations have also been reported in patients with COVID-19 who received Remdesivir, including one patient with ALT elevation up to 20 times the upper limit of normal. As transaminase elevations have been reported as a component of COVID-19 in some patients, discerning the contribution of Remdesivir to transaminase elevations in this patient population is challenging. Hepatic laboratory testing should be performed in all patients prior to starting Remdesivir and daily while receiving Remdesivir. Remdesivir should not be initiated in patients with ALT equal to or greater than 5 times the upper limits of normal at baseline. It should be discontinued in patients who develop ALT equal to or greater than 5 times the upper limit of normal during therapy with Remdesivir. It may be restarted when ALT is less than 5 times the upper limit of normal, or ALT elevation accompanied by signs or symptoms of liver inflammation or increasing conjugated bilirubin, alkaline phosphatase, or INR. Serious adverse effects. An adverse reaction associated with Remdesivir in clinical trials in healthy adult subjects was increased liver transaminases. Additional adverse reactions associated with the drug, some of which may be serious, may become apparent with more widespread use. The instructions for healthcare providers. As the healthcare provider, you must communicate to your patient or parent or caregiver information consistent with the fact sheet for patients and parents and caregivers, and provide a copy of the fact sheet prior to the patient receiving Remdesivir, including that the FDA has authorized using the emergency use of Remdesivir, which is not an FDA approved drug. The patient or the parent or caregiver has the option to accept or refuse Remdesivir. The significant known and potential benefits and risks of Remdesivir and the extent to which such risks and benefits are unknown. Information on available alternative therapies and the risks and benefits of those alternatives must be informed to the patients. If providing this information will delay the administration of Remdesivir to a degree that would endanger the lives of the patient, the information must be provided to the patient as soon as practicable after Remdesivir is administered. All healthcare providers should go to fda.gov and get this emergency use authorization before administering Remdesivir. There are a lot of unknowns. Part of it is all the data from the clinical trial has not been released. In addition, there's another problem. Supplies of the drug are limited and it takes time to make more. The company who manufactures it has been working hard since the beginning of the year, when the idea that Remdesivir might work against COVID-19 was first mooted to increase production. Once again, Remdesivir is authorized for use for treatment of patients hospitalized with suspected or laboratory confirmed COVID-19 infection and severe disease. Severe disease is defined as patients with an oxygen saturation equal to or less than 94% on room air, or requiring supplemental oxygen, or requiring mechanical ventilation, or requiring ECMO, that is extracorporeal membrane oxygenation. Specifically, it's only authorized for hospitalized adult and pediatric patients for whom use of an IV agent is clinically appropriate. More on fda.gov.